Good afternoon, everyone. I don't know if you see my slides. I see them. Okay, so I have no disclosures, no conflicts of interest, maybe just the fact that I'm an interventional cardiologist, but that doesn't count on this slide. So I was tasked by JF and the organizing committee to talk to you about the concept of protected complex high-risk PCI. The other sort of hot potato you might get in the CICU on a busy Friday afternoon with a crash and burn patient, but that's the other, where the patient is stable and you need to talk, and you need to take a sort of a heart team perspective. And this is where, especially with the recent talk that we just had between the panel and the audience, that I think the heart team is something that is important, and we'll discuss this. So learning objectives: what is complex high-risk PCI? What is protected PCI? What is the role of the heart team within this whole concept? So what is complex high-risk PCI? It's almost 40 years now that this gentleman, Andreas Grunzig, started something in 1977 that sort of changed the landscape of not just cardiology, but of the whole of medicine. When you think about it, the early publication from the NHLBI, this is the kind of procedure that I would not want my mother to undergo. Procedural success rates of 60%, emergent CABG 60%, having an OR on standby whenever you want to do this sort of angioplasty. This is how it was back then. Flash forward a couple of decades later, and this is recent data on OECD. Variability, there is some variability across different countries and within countries, but you do see a ratio that changes in favor of PCI for what is a complex CAD, or just standard CAD. However, this is what happens when interventional cardiologists venture where cardiac surgeons refuse to. This is on the left side, you see data from the registry of the Syntax trial. So this is lessons that we can learn. Registry patients in the PCI arm were much older, sicker patients with multivessel CAD and or left main and or LV dysfunction. They don't do well. You see this clearly in panel A. So think about the topic. You can read recent reviews, and this is where I'll reference you to a couple of them. Atkinson sent out a review very recently. My role today is to talk to you about the right side of the slide, the high-risk PCI, and define it much in clearer terms for you. So what is really complex? Complexity really has to do with what we would call on a daily basis difficult coronary anatomy. It's basically an anatomical reference, lesion subtypes that might be associated with the increased in morbidity or mortality rates when you attempt or do perform a PCI on such a patient. Talking about subtypes such as unprotected left main, severe calcification, extensive thrombus burden, bifurcation lesion, extreme tortuosity, degenerated SVGs, CTOs, last remaining conduit, or high-grade, high-syntax multivessel CAD. This is what, the non-type A or B1 lesions that we sort of have become accustomed to, sort of in isolated or at sometimes in combination. So where does the high-risk concept come in? When you really look at the literature, it's a very heterogeneous definition. Other than the standard STEMI patient presenting in cardiogenic shock, which my colleagues talked about early on, one could allude to high risk being a sort of a risk profile conferred by the confluence of three factors, which when taken individually are somewhat surmountable and the patient will do well. But however, when they are combined, will increase the likelihood of poorer clinical outcomes. So we're talking about the first factor, complex coronary anatomy. That's what I just mentioned. Second one would be a potential for hemodynamic compromise or instability. In a stable patient, in a high-risk patient, that would entail LV dysfunction. Other major comorbidities that might make people cringe, advanced age, CHF, valvular heart disease, cerebrovascular disease, chronic kidney disease, chronic pulmonary disease, or severe PAD. So in a context where a patient might be presented to you with a high-risk, complex potential intervention and most likely refused by the surgeon, then this is where we might talk about the concept of protected PCI. What is protected PCI? So I think Mark and Johan have already talked about this. These are the available mechanical cardiac support devices. I'll send you to the different reviews that have been, I think there's a good couple of them, 2 or 3 of them, Mayette and Atkinson's, both in JACC in the last 3 months, so they'll go into details in terms of the device. But other than the intra-aortic balloon, you have 3 other standard devices that are available. So in terms of the logic of it is to really maintain end organ perfusion. Cardiac power output as well as cardiac power index were brought forth by the shock investigators. They were shown to be strongest independent predictors of in-hospital mortality when patients presented in shock in the setting of a STEMI. Hence the logic of trying to increase your cardiac output, and all of these devices have different varying capacity to do so. However, while there are studies that have documented the improved hemodynamic parameters when using such devices in high-risk PCI, there is conflicting data on the impact of clinical outcomes. So I'll try to look at that with you right now. First off, what we do, the run-of-the-mill device that we're all used to doing in the cath lab or in the ICU, the CICU, or with the surgeons as well, is the intra-aortic balloon. Not talking about the cardiogenic subset of patients, cardiogenic shock. I'm talking more about the high-risk PCI patients. So this is the BCIS study published in JAMA in 2010. If you look at what they define as high-risk patients, it's more complex anatomy with poor LV function, all of this less than 25% LVEF. When you look at this, there's not much in terms of difference. There might be numerical difference, but it didn't reach the level of statistical significance in terms of differences in major clinical outcome, whether you pre-planned the insertion of intra-aortic balloon prior to a complex PCI, or you just did not. When you look at the initial study, it didn't come out in the 1-year data as significant. However, when they went to longer-term follow-up, 51 months, there was actually a benefit when a patient had planned intra-aortic balloon insertion. However, in the publication in Circ in 2013, one of the subtypes that was actually of greater interest for clinicians are the crossover. There's about 12% crossover rate in that initial study that really was not looked into or analyzed post hoc to really provide us clinicians to know when to use another device. However, that hasn't stopped clinicians to start using different devices. You could divide the MCSD support devices into 2 eras, pre-2007 and after 2007. This is when you started having percutaneous VADs. And this is when the uptake, if you look on the left side, the red circles, you see a progressive rise over the past few years in terms of use of such devices, since they are percutaneously inserted and might be easier and quicker to use in a dire situation. So they've even started after this 2007 era to talk about anticipated. Instead of having a crash and burn, is to anticipate which patient might end up crashing and burning, and then putting them ahead of time and do preventive, protected interventions, whether it be in EP or in the EP lab or in the cath lab. When you look at due to time limitation, I'm presenting you some of the meta-analysis data. The meta-analysis data doesn't show you that there's that much difference when you look at it. So you're having an interventionalist present you protected PCI telling you that there's not much of a difference. Let's look at some of this data. There's basically in comparative analysis, when you look at the combined data of all the studies out there available in the literature in a recent meta-analysis, there's not much difference that you can see in terms of significant outcomes, whether you compare your PVADs versus an intra-aortic balloon or your intra-aortic balloon to medical therapy. However, one has to bear in mind that when you look at this meta-analysis, there are different definitions when you look at cardiogenic shock and high-risk PCI. I think the previous presenters have alluded to this. The definition is actually key in deciding in terms of your outcome. There are different study methodologies that were used. Surrogate endpoints were not always the same. Treatment modalities, whether if you're looking at the a standard PCI, PCIs, there are many interventionalists in the room, not everybody will do a PCI the same way, yet it's called PCI. So there are varying degrees of treatment modalities and how we use it, and then there's also the follow-up. These differing methodologies are also on the are put on the back burner when you look at this study, because it's sort of a study level and not a patient level analysis. So there are many confounders at the patient level that were not included in this analysis. However, it does shed light on one important fact, that with regards to HRPCI, there is some conflicting data. What I'm going to show you next in the next few slides with the remaining time I have is the protected 2 PCI. The reason why I'm presenting you this is actually the largest randomized trial that we have out there, and it's mainly the one driving what you see in terms of that meta-analysis, in terms of PVADs. And when you look at the inclusion criteria of this study that was performed that was published in 2012, it's non-emergent PCI, and high risk was defined with poor LVEF, 30 to 35%, either an unprotected left main and or 3-vessel disease, or 3-vessel disease in isolation, or a last remaining conduit. When you look at the study methodology, the study was powered actually to have a difference in treatment effect of 33% if they reached 654 patients. However, when you look at the published literature, it's actually a sort of, in French we'd call this un pétard mouillé, and it ended up with 427 patients only. So they managed to do an intention to treat as well as a per protocol analysis of the results. I'll talk to you a bit later on about some of the reasons why this was stopped, and some of the insight that we may have in terms of why the DSMB stopped this trial early, around 427 patients, instead of completing to the level of the 650 or so patients required. So when you look at this, the patients were sick. There were actually little differences except maybe for the history of CHF in terms of patient characteristics. However, when you look at the procedural characteristics, rotational atherectomy and the potential for completeness of revascularization was actually greater in Impella. When you look at rotational atherectomy, just look at the median number of passages. Those of you in the room who do ROTA know that about 2 passages is not very aggressive. A lot of us do a whole lot more passages, more in the range of 5 to 6, if not more so, and incremental increase in your burr size. So this allows the interventionalist to be a much more aggressive interventionalist, especially in a patient that is refused for surgery and done in a non-emergent setting. And we all know the literature, and we can talk about this during the question period if you want, about the completeness of revascularization, whether it's with surgery or PCI, and this again is with data from the syntax. There's about 2/3 of patients that we presume when we send to any interventional, whether it's surgical or percutaneous, that will get the proper intervention, but it's only 2/3 of them that will really get complete revas. So this is sort of an insight that we get from this non-significant trial. When you look at an intention to treat analysis, there's actually no main differences, whether it's at 30 days or at a more midterm setting, which is 90 days later. However, when you look at the patients that did undergo the procedure and did undergo the device and were analyzed per protocol, you actually do see a statistically significant difference at 90 days, these patients doing somewhat better. However, you do realize that 1 in 2 patients will still do badly at 90 days. This goes to tell you that intervention is one thing, but you do need to follow them up and keep medical therapy at its most optimal level. So with such conflicting data in the last 5 or so minutes I have left, what do we make of protected PCI? Can we learn from our mistakes? When you look at this, the data I've shown you has not really sort of made anyone shy away from these percutaneous support devices, again, showing you that same part of the slide with the increasing use of PVADs. However, when you look at the right side of the slide, you actually see that the overall mortality of patients, again, this is patients, the patient population being pulled together, both the high-risk PCI and mainly the cardiogenic shock PCI patient, you actually do see a decrease in mortality rate when you use these devices in the current era. The other important thing, and this is what a lot of people who actually do these procedures, you realize one thing. It's like any technique, whether it's surgical or whether it's percutaneous, there is a learning curve. There is a very specific skill set to manage these patients. These are, like Max said, these are large bore cannula. These are patients that do need a collaborative effort. Obviously, the most competent hands should be the ones doing what is necessary to help the patient out. When you look at this, whether it's with the PROTECT data, randomized data, or sort of a more observational clinical experience from the Mayo Clinic, you do see a difference in terms of when you look at, you either split a cohort into calendar years or into phases of the use of such devices, that you do see a decrease in terms of complication. On the left side, Impella versus intra-aortic balloon, 2008 versus 2010, there is a difference in terms of rates of complication with the use of the PVADs, whereas it's more or less the same in terms of the intra-aortic balloon. When you look on the right side, the clinical experience of the Mayo Clinic shows you that in the early phase of their tandem heart use, they actually have compared, when you see either in gray or in black, the predicted mortality versus the actual mortality, that there is a decrease in mortality when you do use such devices such as the tandem heart PVAD in a proper setting under when used by skilled hands. So again, showing you the reason why some of these data have increased. There is actually nested centers with skilled expertise that do contribute to these two figures, decreasing morbidity and mortality with the use of such devices and increase in use. The goal is not to really talk about whether we should use them more or not. To really, it's how we can do this in a combined fashion. Something's wrong with my slides. They're showing the. I'm pushing. My bad. Pushing forward. Okay. So when you look at some of the, I'm missing one slide before. So when you're looking at some other data out there, the national inpatient sample, when they use the ICD-9 codes to look at the use of these devices, predominantly the intra-aortic balloon, you actually see that there is some differences in terms of mortality. Obviously, these are not randomized data, observational data that you do see. However, it shows you an insight into real-world decision making when people actually take the onus on themselves and take their decision outside of the guidelines. The complication, as mentioned both by Johan and Marc, is not something negligible. However, again, this alludes back to the skill sets that you do need to acquire to do this safely. Other data out there, again, another analysis, a more recent one in 2016, regarding the inpatient, the national inpatient data set with the ICD-9. Again, when you look at the unadjusted hospital mortality, the related editorial actually tells you that this is actually an insight into clinical decision making. This is what clinicians on a daily basis, when they talk to their colleagues, do. When you do have an adjusted analysis, you actually see a trend when you look at the last row, which is the non-AMR, the non-cardiogenic shock, hence the high-risk PCI patient. There is a trend towards benefit. So with all of that, the recent guidelines have actually decided to take a position, sort of a lukewarm position, where you actually do have a Class 2B recommendation to use in select patients these devices when you actually need them in other circumstances other than cardiogenic shock or STEMI. So then, how then do we ensure proper patient selection protection for this concept of complex high-risk PCI? Well, I send you to this great review, 2003 review by Hurd in European Heart Journal regarding the heart team concept. It's actually been more popularized with the TAVR and SAVR discussion, but actually it was initially brought about by this discussion by Patrick Sorois regarding the syntax trial, the patient being at the center of all decision. But this sort of dialogue tells you that there is a need for consistency and coherent decision-making process. It's actually a great paper, and it talks about different motivations why we actually do need a heart team other than a more US-based mentality where there might be some cost-related decision. Other countries such as Canada or Europe might have a different take on the importance of the heart team concept. When I was talking about randomized data versus registry data, you can actually do get an insight on what the benefits are when you do take a heart team approach. The East and Barry trials are well known to everyone. Patients were, some patients were kept in some of the nested registry along with those that were randomized. Patients were discussed with a heart team approach. So it gives you an insight into what is a sort of a patient level or a physician level of preference in terms of what is done or what is to be intervened on. And when you look at such data, such as the East trial, you actually see at 3 years that data is not that bad in terms of survival for the patients that were in the nested registry when clinicians use their clinical judgment and talk to their patients to take the decision. It actually gave you slightly better outcome compared to randomized patients. So with this, the importance of favoring one modality over another in terms of treatment strategy is really left to a discussion that we all need to include everyone. And again, cardiac surgery, clinical cardiologists, as well as interventional cardiologists and the other members of the team that Mark alluded to. However, one of the things when I read the literature, one of the things that is really important when you talk about HRPCI or any type of situation, especially in cardiogenic shock, when you need to take a decision quickly, you need to talk the same language. So there are challenges out there, and one of the challenges is just communication. One of the things that was brought about by the syntax group is a score called the global risk score. This is sort of a score that will allow, in terms of a high-risk PCI, surgeons and clinicians and interventionists to talk to each other in the same language. When you look at this, you stratify the patients either by complex anatomy or by clinical level of risk, Euro score versus syntax score. And when you cross-tabulate them, you actually see patients that might end up, especially the red ones, in a high-risk PCI setting. In such patients, obviously, since you're talking about a syntax score and a Euro score, surgeons, cardiologists, as well as interventionalists will have had to talk to each other. This is one of the key points. I think if we talk about the same thing to each other, then it'll be much easier to understand and then take the best decision for the patient. So going back to this slide, again, cardiogenic shock was talked about by my colleagues. High-risk PCI is an emerging concept with data that is conflicting, and some might even say weak. However, some of the data out there, I think, in terms of the DSMB, for example, stopping the PROTECT-2 trial somewhat early might have been premature. They may have not taken into account the fact that there is a learning curve. Just as, when you look at the States right now, there's a lot of fear using radial artery. People are adopting it since the Sunil Rao paper. However, when I recently visited a center in the US, they were telling us that radial is something ludicrous to do in STEMI patients. So there is different mentalities out there, and there are different ways of doing it. Obviously, my initial conflict of interest being an interventionist, if we all followed guidelines and didn't push any barriers, we'd still be sending patients to surgery, and Grunzig would be the only one doing what he did. However, what we pushed for, and if we do it in a definitive manner, in a randomized and appropriate manner, then I think the data will be there. So concluding remarks, complex high-risk PCI is a reality now facing all of us, clinicians, interventionalists, and cardiac surgeons. Protection with PVAD requires risk stratification, hence dialogue, either with score or clinical judgment. But all of this will only tell us about the need to use these devices, but not necessarily which of these devices to do. So you do need more data. The decision-making process actually will require a, as I've mentioned, heart team-based approach. And obviously, we should strive for better designed randomized trials to guide us regarding what we already know in terms of clinical intuition. Thank you.
Thank you very much, An. Great presentation.